now we go to the questions and answers. We have some questions from the audience. So the first question I would like the Max to answer. So the question is, if you do the airway management with SACO mask, so the mask, and you, for example, you would like to intubate the patient, and there can be some problem with saliva obscuring the view. So, Max, what would be your suggestion to solve this problem with the secretions obscuring the view when using SACO videolaryngeal mask airway?
Well, first of all, thank you for the question. It's really interesting. Well, the SACO laryngeal mask comes with a dedicated channel through which you can push some water, which may be of some help, I mean, some saline solution, which could be of some help to remove the secretions from the camera. And let me say that probably one more advice could be that if you're planning to use this device also for intubation, so to get a really good view accompanying the process of intubation, it could be interesting also to administer some anti-sialagogue medication before you start. So the combination of these two issues should make you able to remove them. Sometimes also some repositioning maneuver can be of help, but actually most of cases simply flushing a little bit with saline and giving my patients anti-sialagogue is enough to keep an acceptable vision, let me say, which can drive you through the intubation process.
Thank you very much, Max. And next question I would like Pavel to answer. The question from the audience is, what is your opinion about possible tissue damage when using UE video stylet? Is there a problem with this, or you can also suggest some tips and tricks how to avoid the tissue damage of surrounding area of the larynx and the larynx when using this stylet?
Okay, Thomas, thank you very much for this interesting question. There is one very important point to prevent damage, is that the tip of the stylet should be hidden partially inside the tube. So as you remember from my presentation, if you look at the screen of the monitor, in the first time you should see on the right upper bottom the part of the tip of your tracheal tube. So this can decrease the risk of trauma because your rigid instrument is hidden inside your relatively soft tracheal tube. The second thing is the selection of the patients. If you have, of course, patients with any kind of bleeding subject inside the airway, such as tumor of the tongue, epiglottis, or tonsils, or any other kind of potentially bleeding thing inside your oropharynx, I wouldn't recommend using UE video stylet, but I would use flexible endoscope instead. The third thing, if you don't have enough space or if you have very limited space, I would recommend to use Professor Gashinsky technique and help yourself with the classical or video laryngoscope just to create some space inside the airway. And the last thing is that your advancement should be very careful, and always when you see nothing, it means when you see only pink tissue or saliva, you should either suck it out or return slightly back, because you should always be able to see some structures, such as in flexible endoscopy. And actually, the damage to the larynx, I think using proper technique, correct technique, the risk is very low because you don't advance that rigid middle instrument inside the trachea. You should only advance it till the laryngeal inlet and then reload the tube under direct vision to trachea. Thank you.
Thank you very much, Pavel. And again, question to Max. What do you think about indications for videolaryngeal mask airway, and what time of the surgery would be the limit of using this? And what is your opinion of using laryngeal mask, especially videolaryngeal mask, SACO mask in laparoscopy?
Thanks, Thomas. So I see here the questions on the screen. I think I can combine an answer. So the first thing is about sizing. When we were starting using the laryngeal masks, whatever, they were provided with a table suggesting the sizing based on weight. But who is dealing with obese patients know that weight can be tricky. So exactly like you work on ideal body weight for some medication, you should think differently when you use a laryngeal mask for a patient, for an obese patient. As for my experience, probably more than weight, height is important because the cuff of the mask has to sit in the laryngeal inlet. And technically speaking, you can have only two variations. The first one is the height of the space, which is linearly related to the height of the patient. And the second one is probably the amount of fat tissue which can surround the structures. So actually, I would keep the choice of the mask on the ideal body weight of the patient. I would not go, let me say, blindly to the larger available size, because it doesn't mean that if you are overweight, your pharyngeal inlet or your laryngeal inlet are larger than usual. And as a general rule, I always like to have a larger number mask, less inflated, rather than a smaller number hyperinflated, because the surface is different, especially when you use silicone cuffs. So my advice would be choose based on ideal body weight and move to a larger size only if the patient is taller. But above all, do not hesitate to change the size if you're not happy with the results with the ventilation and tests. The longest surgical time I recommend for the videolaryngeal mask is based on a principle of any laryngeal mask. The real benefit of laryngeal mask is seen on short procedure or not so long procedure. So if you need to keep a patient for more than 3-4 hours on the supraglottic, much better to switch to the endotracheal tube, mostly for two reasons. The first one is what Archie said: when you're using a tube and the laryngeal mask, there's a big difference. If you use a tube, either the patient or the anesthesiologist may sleep. If you use a laryngeal mask, the patient may sleep, but the anesthesiologist needs to be awake. You need more control on these devices, so the tube is more forgiving. So if you have a longer procedure, much better to go on a tube, even because you may be supposed to move that patient to ICU, so you already have the tube in. One of the advantages of the SACO BLM could be that you can start supraglottic, and if for any reason the procedure gets longer, you can easily switch to intubation. Benefit and everything for laparoscopic surgery. Well, laparoscopy is an advanced use, so I recommend to get familiar with the mask in daily practice for easier cases than to try to push it a little bit to the limit. Advantage is the same if you're going for short procedures. If you want to take the maximum benefit, turnover rate in OR, a fast recovery, and whatever, I suggest to use it. Otherwise, if you're going for a robotic head down, which lasting more than 4 or 5 hours, actually, you lose all the potential benefit of using a videolaryngeal mask or a laryngeal mask in general over a tube. So these would be my recommendations.
Thank you very much, Max. And as my practice, I deal a lot with obese patients. I absolutely agree with you that the body weight is not, in fact, indicator, but rather the height and body composition and the composition of the neck. This is very important to choose the right side. And in fact, what is quite surprising, maybe for other anesthesiologists, laryngeal masks, supraglottic devices, generally, they work very good in obese patients, but we should know that this is for temporary ventilation, for short procedures. And now still the endotracheal intubation is preferred method for airway securing in obese patients for longer operations, for operations, laparoscopy operations, or operations in non-standard positions. Thank you very much for this. And the next question, I suppose I will answer. This is about UEDA video laryngoscope. I already mentioned about some features that are comparing to the standard, to the very often used Graph Mark video laryngoscope. So what can I say? What are the advantages of using UEDA video laryngoscope over those other video laryngoscopes? Is first, very good display, very good quality of a display monitor. Secondly, this diameter of the blade. This is when you compare this to other video laryngoscopes, the UEDA video laryngoscope has, in my opinion, as far as I know, the smaller the diameter of the blade. So as I said during the presentation, it's for patients with some kind limited mouth opening, better to have thinner blades, because this may influence the success of insertion and of the blade and intubation. And okay, so now we have some last question that I would like to ask to all of you, all of presentators. What is your suggestion about what would be your parameters that you would suggest as as a choice for this product over the other products in the market? So maybe Pavel would start. Please tell us what would be your why you choose, what would you choose UE products over other products in your practice?
Well, I would modify a wee bit the answer, because I'm not very happy to promote any branch in the world. Well, so I always prefer better products over the branch names, you know. So I can talk about video stylets and UI video stylets concretely. Actually, I have slightly changed my Airway practice within last 2 years since I've started with the video stylets. We have about 5 different brands of video stylets. And if I have patients with predicted or known difficult airway, with no intraoral pathology and with at least some mouth opening, I would prefer video stylet over flexible endoscope. And the reason for is that it's faster, and for the patient it's less burdening than flexible endoscope. While with good experience you can perform oral intubation with the UE or other video stylet within 1 minute. Flexible endoscopy always takes 3 to 5 minutes at least.
Thank you very much, Pavel. And Max, of course, again, I don't want you to advertise, to do advertisement of specific products, but could you just suggest what would be your suggestion about features of some products that would influence your choice for the airway management in your patients?
No, actually, when we think of airway management, we need to think of something which is also relying on individual preferences, competences, skills, and everything. So you may not be able to recommend a product which is good for everyone. So I think that our duty as experts is just to recommend which are the criteria that should be respected. So for sure, when speaking of a laryngeal mask, what I would recommend is the quality of the material, because you can't run the risk of having some accidents during their use. What I would recommend is the efficacy of sealing. So always test your device for sealing pressures and everything. And actually training. I think that If a device has a certain quality, you can get the best out of that only with adequate training. So don't think that you get a laryngeal mask, whichever it is, for the first time, and you can do prone position or laparoscopy, because you need to know the device to develop adequate training. So my recommendation would basically be just don't choose those devices which are not staying in efficiency, efficacy, and safety. All the rest comes from your own preferences and from your own training. The more you use the device in elective procedures, the more you will get the best out of it also in emergency cases.
Thank you very much. And I would like to add some of my suggestions. So talking about why would I choose UE product stylet, video stylet over other stylets, because the other stylets, especially those elderly stylets, intubation stylets, they are not video stylets, they are optical stylets. So you have to either connect them to the camera, or you should look at the ocular. So if you have the camera, you have the monitor, display monitor on the handle of the stylet, intubation stylet, video stylet, it's definitely better, easier to use. As for a video laryngeal mask, I really like video laryngeal mask because you can observe not only the proper position of the mask when you insert it to the airway of the patient, but also you can control the positioning of the mask during the procedure. So you can have continuous control over the position of the this video laryngeal mask in the airway of the patient. And this what I said about the blades, the diameter of the blades. If you have the blade with a very short, very small diameter, it's definitely, in my opinion, better because it's easier to insert it to the mouth of the patient. Okay, so I think that would be all the questions that we received from the audience.